So when we look at the functional GI disorders, we now call them disorders of gut-brain interaction because we're looking at how the brain and the gut are talking to each other. There's no organ as closely connected to the brain as the gut because it has its own nervous system. So the brain and the gut regulate each other, and that can lead to problems in terms of pain or diarrhea or constipation if it's not working right. Another interesting component more recently is what we call the microbiome. And in many ways, we're just beginning to understand how much the bacteria might play a role in gut function in terms of its integrity, in terms of susceptibility to disease, certainly infectious diseases, but even irritable bowel. If you have altered bacteria or an infection, you might develop irritable bowel syndrome. We also know that the bacteria may even play a role in psychiatric functioning. There are animal models to show how so-called bad bacteria can produce difficulties in mental functioning. And so the idea of this interaction has relevance from the microbiome, the bacteria, to the neural plexus of the gut, to the brain. Well, Trulance is one of the chloride channel agents like linaclotide, lubiprostone. It may, in its studies, may reduce the amount of diarrhea that can occur with some of the other drugs, but it acts at the chloride channel, and it has been shown to improve the constipation, increase the number of spontaneous or complete spontaneous bowel movements, and as well as reduce the pain. So, C. difficile, when it first came out, it was pretty limited to a narrow spectrum of antibiotics. Clindamycin was the first one, and it's a bacteria that then overgrows as a result of the antibiotic, reducing other bacteria. Over time, what we've started to see is a broader spectrum of antibiotics leading to it, and particularly in hospital settings for older patients, postoperative patients, it's growing almost, I wouldn't say it's going to high levels extremely fast, but it is growing considerably. And with that, what we're finding is that there can be resistances. And so about 15% or 20% of patients who get treated may develop it again because they have spores. So you treat the bacteria, spores continue, and then later it comes out again. So one of the big problems these days is many of these patients have to be retreated. And as you have a greater number of people getting it, then you have a greater number of people having resistant C. difficile. I think the new kid on the block is looking at fecal transplant because that has been shown to be very effective for these patients who are refractory to repeated treatment, usually with vancomycin.